So, hi students, welcome to this session where I've tried to recollect the pediatric questions in the recently concluded NEET PG 2021 exams. Now, this was the basic attempt or aim of this session is to recall as many pediatric questions as we can recall and discuss their answers. Whatever answers I have given in this recall video is primarily based upon the questions that the students have provided. Because these are very early days, the exam was yesterday, so the students have not been able to exactly recall all the questions. But as and when more questions I'll come to know, I'll probably be very happy to provide a more exhaustive list of those questions along with their answers. Uh, these questions, again, I'm telling, are questions that have been recalled by the students. So the structure or the framework of these questions is a little incomplete because this is how I have come to know what are the primary things that are being asked in this question. And the choices also are not complete in all the questions. But let us actually have an understanding of the questions and the answers based upon the questions that have been asked. So the first question that was asked in the NEET PG 2021 pediatric question was, one question was an 8-year-old boy presenting with edema, pallor, hyperlipidemia, urine dipstick of 3 plus. Now urine dipstick of 3 plus is significantly large amount of protein that is passing in urine. And when the child has a significantly large amount of protein passing in urine, which usually is called as pathological proteinuria, and along with pathological proteinuria, the child has edema and the child has hyperlipidemia. So the child has edema also and the child has hyperlipidemia also. And along with this, if the child has significantly high concentration of protein that is being excreted in urine, then it is a clear-cut case of a nephrotic syndrome. So the answer to this was pretty simple: nephrotic syndrome. In my eGurukul videos, I've discussed about nephrotic syndrome. This is a topic which you are all very familiar with. It's basically a topic which is quite commonly asked in exams. This is a disorder which presents with selective proteinuria, especially albumin and low molecular weight proteins being excreted in the urine, which primarily is the reason why these children often have hypoalbuminemia. Then they have high cholesterol levels. Usually the levels of serum cholesterol is more than 200 milligrams per deciliter. And the primary reason for hypercholesterolemia in these cases usually is believed to be lipoprotein synthesis by the liver, increased lipoprotein synthesis. There are many contributory factors which can contribute to the development of hyperlipidemia, but this is one important contributory factor. Plus other factors that may contribute to the development of nephrotic syndrome or other associated findings may be hypercoagulability and increased risk of infections, particularly because of the collection of fluid in the interstitial spaces, which can predispose these children to infections. Also the loss of complement factors and immunoglobulins in the urine, which are low molecular weight proteins. So this can contribute to the development of infections such as infections by Streptococcus pneumonia. So this all has been discussed in my eGurukul videos about nephrotic syndrome. And here I don't think there would have been any other choice other than nephrotic syndrome which would have fit the answer. Anyway, we do not know what were choices C and D. The students could recollect only nephrotic syndrome and nephritic syndrome. But because most of the students, because they were pretty sure about the answer nephrotic syndrome, so they told me nephrotic syndrome only was one of the choices that they could recollect. So a child presenting with edema, presenting with hyperlipidemia, presenting with high amount of protein excretion in the urine, which is called as pathological proteinuria. And as you can see here, pathological proteinuria usually means a urine protein excretion which is more than 1000 milligrams per meter square per day, or more than 3.5 grams of protein per day. Or another way of calling pathological proteinuria is when the urine protein to creatinine ratio is more than 2. So normally it is less than 0.5 in children who are less than 2 years of age, and it is less than 0.2 in children who are more than 2 years of age. So 0.222 of urine protein to creatinine ratio is a high amount of proteinuria. But when this urine protein to creatinine ratio becomes more than 2, then it obviously becomes a significantly high proteinuria or pathological proteinuria, and that is what defines nephrotic syndrome. So pretty simple answer here, nephrotic syndrome. Let us come to question number 2. Now, according to our students, question number 2 was a question which was talking about a child presenting with absent femoral pulses, with increased blood pressure in the upper limbs and dilated intercostal artery. Now, this again is a pretty simple answer. The answer here is the child presents with coarctation of aorta. There are two important findings that will immediately tell you that the child may have a coarctation of aorta. First, the upper extremity pressure, blood pressure, is more than the blood pressure in the lower extremities. And the second very important finding that can tell you that this child possibly is having a coarctation of aorta is that the child is presenting with very weak pulses in the lower extremities, especially the femoral pulses, the dorsal pedis pulses. These usually are very weak. So what is coarctation of aorta? Coarctation of aorta is a constriction in the arch of aorta. Again, in my eGurukul videos, I have discussed coarctation of aorta in quite detail. It's basically a constriction which is present in the arch of aorta, just distal to the origin of the left subclavian artery. So it is usually present just distal to the origin of the left subclavian artery along the or in the arch of aorta. Now, since this position from where the constriction is present is very near to the origin of or attachment of the ductus arteriosus, that is why this is sometimes also referred to as a juxtaductal constriction. So if someone asks you what is the point where coarctation of aorta or constriction in the aorta is present, it normally is present in the arch of aorta, just distal to the origin of the left subclavian artery in the arch, and it is very near to the point where the ductus arteriosus is attached. You know, the ductus arteriosus connects the pulmonary artery to the arch of aorta. So since this constriction is present very near to this arch, to this place where the ductus arteriosus is attached, we often call this as a juxtaductal coarctation. So most children who present with coarctation of aorta have juxtaductal coarctation, although a more severe variant of coarctation, which presents with the whole transverse arch being hypoplastic, that can also be seen in some. This obviously, because it's a more severe presentation, will present primarily in newborns just after the ductus arteriosus closes, immediately after birth. So this is primarily a presentation which is seen in neonates. Otherwise, most cases of coarctation of aortas have a presentation usually later in childhood, and these children typically presents with problems of blood flow or symptoms associated with problem of the blood flow reaching the lower extremities. So there will be symptoms such as symptoms of intermittent claudication or pain and weakness of the legs while walking. Then there will be blood pressure differences between the arms and the legs. So if you take the blood pressure of the arms and blood pressure of the legs, the blood pressure of the arm usually is known to be higher than the blood pressure of the legs. That obviously is expected because of the limitation of the blood flow to the lower half of the body. In addition, there is presence of radiofemoral delay and weak pulses of the lower extremities. And in this case, if you see the question had the blood pressure in the arms are more in comparison to the blood pressure of the legs, and there was also presence of weak or absent femorals. So I think the question clearly indicated that the child has a coarctation of aorta. Now, to overcome this constriction of coarctation, normally intercostals and intercostal arteries usually are formed. Intercostals and internal memory, which is a branch of the left subclavian, usually are known to bypass these obstructions. And because of these dilated intercostal arteries, you often have the child presenting with typical X-ray finding, which is a figure of 3 sign, and there will be notching of the ribs, notching of the underside of the ribs, which usually is because of the dilated intercostal arteries. So dilated intercostal arteries, why are they dilated? Because they obviously are the only route which help in bypassing the obstruction in the arch of aorta, along with the internal memory artery. So here also they have mentioned that there was dilated intercostal artery. So everything clearly points out to the fact the child had a coarctation of aorta. So in this question, the answer was coarctation of aorta. Again, a very, very easy and doable question, which I'm sure you all would have marked correctly. Now, question number 3. Now, here there is a slight discrepancy. Some students are saying that there was a history of a child who presented with fever and with fatigue, and the child presented in the hospital. The X-ray was given, and the X-ray showed a typical finding, which is shown here, which is a sign of 8 or a snowman's heart appearance. So in any case, if this type of an X-ray was given, which is typically an X-ray showing a figure of 8 or a snowman's heart appearance, again, in my eGurukul videos and in my classes, I typically show this type of an X-ray when I'm describing a supracardiac TAPVR, a supracardiac total anomalous pulmonary venous return. It's sometimes also called as supracardiac TAPVC, total anomalous pulmonary venous connection. So this is a condition in which all the 4 pulmonary veins, instead of opening up into the left atria, they open into the wrong chamber, which is into the right atria. So these 4 pulmonary veins, they first join together to form an ascending vertical vein. So this ascending vertical vein is producing a typical, this ascending vertical vein is producing a typical shadow, which is on the left side of the X-ray. Then all these 4 veins which have opened up into the ascending vertical vein, this ascending vertical vein will send the blood into the superior vena cava. So the superior vena cava, which can be seen as a dilated shadow on the right side. So there is a dilated shadow on the left side, which is the dilated ascending vertical vein, a dilated shadow on the right side, which is the dilated superior vena cava, as the ascending vein is opening up into the superior vena cava, and below you have the large heart. So that is why we have a typical snowman or figure of 8 appearance. This is the typical finding of a child who has a supracardiac total anomalous pulmonary venous connection. So the answer should be TAPVC. But let me remind you, this is typically a finding that is seen in supracardiac TAPVC. Infracardiac TAPVC usually presents with another type of finding, more like a ground glass opacity type of a finding. It usually does not present classically with a snowman's heart appearance. Snowman's heart appearance is classically seen in a child who presents with a supracardiac TAPVC or a supracardiac TAPVR. So this was the answer to question number 3. Now there are some students who are saying that in their X-rays that was given to in their exam, a boot-shaped heart was seen. So in case a boot-shaped heart was seen, in that case the answer would have been tetralogy of Fillet. I'm still not very sure. It is quite likely that there would have been separate images for a separate set of students. I really do not know. But in case there are many of them who are quite confident that the X-ray that was given to them was a boot-shaped heart, which usually indicates TOF. So a figure of 3 appearance, coarctation of aorta, a boot-shaped heart, TOF, a box-shaped heart, Epstein's anomaly, a figure of 8 appearance, supracardiac TAPVR, egg on a string appearance, usually seen in TGA, and ground glass opacity type of an appearance, apart from hyaline membrane disease and alveolar proteinosis. It is also sometimes seen in infracardiac TAPVR. These are some of the classical X-ray presentations that you should remember, which I normally always teach in my classes. So I'm sure be it TOF or be it TAVC, you would have been able to answer the questions correctly based upon what question was asked to you in your exam. Now coming to question number 4. Now question number 4 was a question where the students are asking, sir, the question was framed in a way that a child is a known case of HIV. His CD4 counts is 50. Which vaccine should be avoided in this child? Now this again is a pretty simple question. They are not able to give me exactly the other choices, but this is again a very simple question. HIV usually is a condition which is or disorder which is associated with an immunocompromised state. So it is very rational to believe that live attenuated vaccines will be very dangerous, particularly when the child has a symptomatic HIV or a severely immunocompromised state. So it is widely recommended that live attenuated vaccines such as BCG, such as OPV. These should not be given in children who have HIV, especially BCG and OPV. You can always prefer IPV to OPV in these cases. Regarding measles and MMR vaccines, which again are vaccines that are measles and MMR vaccines again are vaccines that are live attenuated vaccines. Now, these vaccines, according to recommendations, can be given only in selected cases of HIV children who have a CD4 count of more than 15% of expected for their age. So, if a child has a CD4 count which is more than 15% of the expected for that age, then after a detailed counseling of the parents about the risk, and if you are finding the benefits of giving a measles or MMR vaccine to be much more and outweigh the risk of giving this vaccine in severely immunocompromised children with HIV, then you might consider it, but only again when CD4 counts are more than 15%. That means again in a severely immunocompromised child, even measles and MMR vaccines should not be given. They are contraindicated. And a child with a CD4 count of 50 is obviously a severely immunocompromised child. So always remember, live vaccines to be withheld. BCG vaccine not to be given. OPV vaccine avoid. Prefer more IPV vaccine in place of OPV. Regarding measles MMR, again avoid it. But if the child has a CD4 count which is more than 15% of the expected for that age, after a detailed counseling of the parents regarding the benefits and regarding the risks of this vaccine in an HIV child, you can give the HIV vaccine, but only if the CD4 counts are more than 15%, not if the CD4 counts are less than 15%. So again, the answer here should be MMR vaccine, which should be avoided in all children who have a very low CD4 count, such as a CD4 count of 50. This again in my eGurukul videos I've discussed about vaccination in or immunization in special categories of children, in which one categories of children are children who are immunocompromised, such as children who are on chronic steroid therapies or children who have HIVs. In those children, how to vaccinate the children, how to vaccinate preterm children, how to vaccinate children who have undergone splenectomy or are going to undergo splenectomy. So these are some of the things that you need to know before you give your exam. These are very important topics related to immunization. And we have a question which was asked on one of these topics. Then another question that students say was asked was, a baby presents with tachypnea. In the emergency, the child has a carpopedal spasm. What is the most likely cause for this? Now this again is quite simple if you understand that when a child is having tachypnea, tachypnea will always predispose a child to CO2 washout. And when there will be a CO2 washout, it obviously will predispose the child to the development of alkalosis. And since alkalosis is known to increase the binding of calcium to the protein, especially albumin, so obviously it will make less of ionic calcium available. And if less of ionic calcium is available, it obviously will present with signs of hypocalcemia. So alkalosis is known to present with hypocalcemia. And let me tell you one thing more. Respiratory alkalosis will predispose more to symptomatic hypocalcemia compared to metabolic alkalosis. So here the answer therefore should be alkalosis. It's alkalosis which is predisposing to hypocalcemia. And what is the hint that the child has hypocalcemia? The hint is the presence of a carpopedal spasm. This is a typical symptom of a child who has hypocalcemia. You must have heard about Shostak sign and the Trocheus sign, which are classical symptoms of hypocalcemia. Shostak sign is when you tap in front of the external auditory meatus, you have ipsilateral twitching of the facial muscles. And Trocheus sign is increasing the blood pressure by applying a cuff, increasing the blood pressure above 20 millimeter mercury above the normal blood pressure levels, and you can see a typical carpal spasm that will be induced by this. So these symptomatic hypocalcemias are much more common with respiratory alkalosis in comparison to metabolic alkalosis. And there has again been quite a debatable point about which of these is a more specific sign. According to me, out of Schwastic sign and Trosche's sign, it's Trosche's sign which is a more specific sign in comparison to the Schwastic sign. So this question, question number 5, answer was tachypnea leading to carpopedial spasm. The cause is alkalosis. Then there was a question which was asked on HSP. In my classes, I've again discussed Hinox-Schönlein purpura in quite a detail. The question was an 8-year-old boy has palpable purpura in the lower limbs. The child additionally has symptoms of abdominal pain and joint pains. So what is the diagnosis? So diagnosis is pretty simple. It is a Hinox-Schönlein purpura. So in my eGurukul videos, I've discussed about Hinox-Schönlein purpura or IgA vasculitis in quite a detail. It's a type of a small vessel vasculitis in children. There is a lot of debate about whether HSP or Kawasaki's disease, which of them is the most common vasculitis of childhood. So Hinox-Schönlein purpura is a very, very common small vessel vasculitis. Overall, also many people believe it to be the most common vasculitis of children. Typically presents in the age group of around 3 to 8 years or 4 to 8 years, and the typical classical triad of symptoms. So you can see in my eGurukul videos, I mentioned this. The classical triad of symptoms. This is a direct cut or a direct slide presentation or a direct presentation of the image from my eGurukul video. So I have mentioned that a combination of abdominal pain, joint pains, arthralgias, along with the presence of a typical rash, and I've shown the pictures also in my classes, where the rashes are present usually in the dependent portions of the body. So they appear as palpable purpuras, especially along the waistline and along the lower extremities. Even when you see them in the upper extremities, very rare, but they will usually be present below the elbows. So they usually are palpable purpuras which are present in the dependent portions of the body. I normally discuss this in the nephritis section, glomerulonephritis section, because 30 to 50% children have glomerulonephritis, which usually develops about 3 to 6 months after the onset of Hinox-Schönlein purpura. And the renal biopsy findings of a child who has nephritis secondary to HSP is typically similar to the renal biopsy findings of IgA nephropathies. So that is why many people believe that these are two disorders which usually have the same inheritance. So according to me, this also was a very doable question, and I'm sure all the students who have attended our classes would have been able to answer this question. It was a very typical presentation of a child who has HSP. A child presenting with abdominal pain, child presenting with joint pains, and child presenting with palpable purpuras. The answer is quite simple, that it is HSP. Then according to students, another question that was asked in the exam was a question about the Tura poisoning, anticholinergic symptoms. So typical anticholinergic symptoms were given in the question. So a child accidentally has ingested some fruit while playing, and the child had dry skin, urine retention, increased temperature. All of these are typical anticholinergic symptoms. So the Tura poisoning usually is known to present with typical anticholinergic symptoms. So these children often have flushing of the face. They often have dry skin. They often have mydriasis, which I don't know was in the question or not, but they often have dilated pupils, mydriasis. Then they often present with urine retention. Then they often present with decreased bowel activities. So all of these are classical anticholinergic symptoms. Which can be induced by the Tura. So I really do not again know. Some students are saying they ask these symptoms are attributed to which poisoning. Some asked that they ask the drug of choice for this. So in case they ask the drug of choice, the drug of choice for this is physostigmine, which again to me is not a demanding question at all. This is Pretty simple findings that have been given in the question. These are the findings which are all anticholinergic symptoms. Anticholinergic symptoms often are associated with the Tura poisoning. Children inadvertently, accidentally, often ingest it, and they have all these type of presentation symptoms. The treatment is usually physostigmine. So again, for me, a very doable question. Coming to question number 8, very simple question. Again, we discussed fetal circulation in detail in our classes. I'm sure this question overlaps with a question of overlaps with physiology also, or probably anatomy also. I put this in my section because I normally teach fetal circulation in detail, and we have discussed in detail about the fact that umbilical artery is the only second artery in the body which carries deoxygenated blood apart from the pulmonary artery. So arteries normally always carry oxygenated blood except for the pulmonary artery and the umbilical artery. Similarly, veins normally always carry deoxygenated blood except for the umbilical vein and the pulmonary vein, both of which carry oxygenated blood. So here the best answer will be deoxygenated blood in the fetal circulation is carried by the umbilical artery. The placenta is the main organ which is performing the function of oxygenation in the fetus. It's not as efficient as the lungs after birth, but still it is quite an efficient organ which performs oxygenation of the blood. And the umbilical vein which arises will be carrying more of oxygenated blood with the PaO2 of almost around 30 to 35 millimeter mercury. And since this umbilical vein, 50% of this blood bypasses the portal circulation through the ductus venosus and enters into the inferior vena cava. So the inferior vena cava oxygen tension, partial oxygen tension of inferior vena cava will become high. As far as I remember, PaO2 of inferior vena cava is almost around 26 to 28 millimeter mercury, which is much higher than the the PaO2 of superior vena cava, which is just about 12 to 14 millimeter mercury. So why is superior vena cava having a PaO2 of just about 12 to 14 millimeter mercury? Because it is primarily deoxygenated blood. The PaO2 of inferior vena cava increases because the umbilical vein through the ductus venosus pumps oxygenated blood into it. So obviously the oxygenation tension of the umbilical of the blood in the inferior vena cava will increase, and this primarily oxygenated blood is then pumped into the right atria, and from the right atria through the foramen ovale then it goes into the left atria. I'm talking about the fetal circulation. So in the fetal circulation, deoxygenated blood is primarily carried by, answer will be the umbilical artery. Oxygenated blood is primarily carried by the umbilical vein. So again, a very easy and doable question. Then students tell me about a question which was a question on cystic fibrosis possibly. Again, I'm getting a broken type of a question where I'm not getting the exact sentences. So whatever answer I'm trying to give is an answer which is primarily based upon whatever statement has been provided to me. So the question that students tell me, some of the students have told me, is that a 10-year-old boy present or 10-year-old child presents with history of recurrent pulmonary infection and has now presented with bulky stools with a stool fat which is more than 10 grams. Now, a child who is presenting with malabsorptions, steatorias, a child who is presenting with recurrent chest infections, a child possibly who is having failure to thrive. I'm not sure whether the child's weight was given here or not, but a child who possibly is having long-standing malabsorptions, who is probably having recurrent chest infections, he's quite likely to have cystic fibrosis. Again, I'm again and again saying, please remember, this is based upon whatever feedback of the question I've got from the students. If there are any other statements relevant which were missed in this part of the stem of the question, then answer can change. But according to this typical history, I feel the diagnosis should be cystic fibrosis. In case the diagnosis is cystic fibrosis, that what all presentations of cystic fibrosis can be there. One typical presentation, apart from recurrent chest infections and malabsorptions, is the presence of meconium ileus. So this dry plugs of meconium block the distal part of the intestine, but that happens primarily in the neonatal period, does not happen in the age of 10 years. So students tell me that the question had one option, the distal intestine obstruction can be present at this age, which probably is incorrect, cannot be the answer here. Because at 10 years of age, you rarely have children who present with features of distal intestinal obstruction in cystic fibrosis. Similarly, there will be high concentration of sodium and chloride in the sweat. There is no feature of hypernatremia that will be seen in these cases. Sweat contains very high concentration of sodium and chloride because of the dysfunction of the CFTR receptors. The fourth choice students were not able to tell me. Third choice, they were saying that some students were saying that they primarily asked rectal prolapse may occur in this child. If rectal prolapse may occur in this child, some students are saying rectal prolapse may occur after the treatment in this child. I'm really again not sure. There are other students who are saying rectal prolapse may occur in this child. Please remember, in case rectal prolapse may occur in this child is one of the options, it can be a feature of cystic fibrosis. It's a well-known feature of cystic fibrosis. Although the cases of rectal prolapse have now declined in children, the rectal prolapse in these children is probably because of those dry, bulky stools that are present in the intestine, plus because of malnutrition, which contributes to the development of prolapse of the rectum in these children. And let me tell you one thing more. Rectal prolapse as a feature of cystic fibrosis is much more common in infants in comparison to older children. But still, if I am not getting the fourth choice, what was the fourth choice? And this is the total stem of the question, then I feel cystic fibrosis appears to be a reasonable diagnosis. And along with cystic fibrosis, if I'm asked what other presentation can be there, and if choice C was only rectal prolapse may occur, then this is the correct answer. It may occur in these children because rectal prolapse is a known finding in children who have cystic fibrosis, although not a very common presentation. More common presentation in children who have cystic fibrosis is the presence of malabsorptions, presence of failure to thrive, presence of recurrent chest infections, presence of cholestasis, presence of conjugated jaundice because of cholestasis. In newborns, often presents with meconium ileus. And then in adolescents, even the endocrine part of the pancreas can get involved. So there are cases where diabetes has also developed as a result of cystic fibrosis in adolescents. So after the age of around 10 years, in all cases of cystic fibrosis, even the oral glucose tolerance test is recommended to be done if a child has cystic fibrosis. So again and again, I am saying this is a disclaimer that you need to remember. I am primarily giving my inputs based upon whatever stem of the question is carrying the statement and based upon the limited choices that I have got from the students. In case there would have been more relevant choice, or in case any of the choices that I mentioned in the question, any of those choices had additional statements, possibly the answer can also be different. So anyway, if this is the total question and these are the choices that have been given, I think rectal prolapse is a decent answer because rectal prolapse can occur as a complication of cystic fibrosis. In case I get the complete questions later on, I'll be more than happy to present a complete version of these recall questions at a later date. Coming to another question that was asked, again a question where students are giving different versions. The question was, a 4-year-old child who has a ventricular shunt for hydrocephalus got it replaced because of shunt malfunction. The child now presents with irritability and loss of appetite for 3 days with no other symptoms. The rectal temperature was 38.7 degrees centigrade. What would be the next step of management? So children who present with obstructive hydrocephalus often have to undergo shunts, and these shunts can be ventriculoperitoneal shunts, ventriculoatrial shunts. So ventriculoperitoneal shunts are often used in the management of obstructive hydrocephalus or hydrocephalus in children. And one of the basic problems that can be associated with these shunts is the complications. The two main complications that can be associated with these shunts, the two main complications One is shunt occlusion, which can occur either because of cells, it can occur because of debris. In tubercular meningitis often occurs because of the very high protein concentration. And the second thing that can happen is shunt infections. These are two important complications of the shunts, ventriculoperitoneal shunts, which can lead to shunt failures. Now, differentiating between them based upon the symptoms alone can be very, very difficult, because more or less both of them, shunt occlusions also and infections also, will present with almost similar findings, especially the findings of raised intracranial pressure. Yes, in cases of infections, sometimes fever can also be there. Fever often is a low grade fever to high grade fever depending upon case to case. Now, in this case, what I see is that the temperature of the child is 38.7 degrees rectal temperature, which means if I calculate it, oral temperature should be above 101 degrees Fahrenheit, which means the child had fever. So the child is febrile. So any child who is febrile and any child who is presenting with loss of appetite and who is presenting with irritability, which are very non-specific signs but can be signs of raised intracranial pressure, and the child has recently undergone a revision of shunt, then probably it might be possible that the child had a shunt infection. So I am seeing this as a case of a shunt infection. Again, unless and until there are some additional relevant points or statements that were there in this question, which can change the answer, based upon my limited knowledge about whatever has been presented to me, I would say this is possibly a case of a shunt infection that has happened in the child. So basically what they are trying to ask you is, how should this shunt infection be managed? Now see, basically when shunt infections occur, or basically when you suspect shunt infections, symptoms of raised intracranial pressure, irritability is there, papilledema is there, or there are signs of a child having recurrent vomitings, or the child is having headaches. So in such cases, and the child is febrile, in such cases, you might suspect that the child may have infections. And when you have shunt infections, obtaining the CSF for culture is very important. Now, there has been a lot of debate as to what is the primary CSF that helps in this case. Would be a lumbar puncture and then obtaining the CSF, or would be the other option of doing a CSF or obtaining the CSF from the shunt reservoir. So there have been two ways by which the CSF has been obtained. One is by obtaining it from the shunt reservoir, or possibly by doing a tap of the shunt, and the second is by doing a simple plain lumbar puncture. Now there have been various reports which have compared these two methods. Shunt reservoir and taking the CSF from the shunt reservoir appears to be a little complicated procedure in comparison to a lumbar puncture, possibly associated with more morbidities and mortalities, although uh, overall the organism growth which can be cultured from these two almost remains the same, or the chances of the organism growth remains the same. But many people still believe that shunt reservoir or obtaining CSF from the shunt reservoir may be a better option in comparison to a lumbar puncture, may probably give you a much better growth of the organism in comparison to lumbar puncture. So among the choices that were given to me, what I could see was, one choice was blood culture, the second choice was blood culture and CSF from the shunt tap, third was start IV antibiotics, fourth, again they were misleading, or they were statements that actually students were giving, which possibly they were statements which are contradicting each other. So I have not put that statement D, but students have obviously provided the best that they could recollect. They were more busy. It's quite understandable that all our students were much busy with their exams, which should be their first priority. So whatever I could get from the students was that these three were the primary choices. D I have not written because they were contradictory statements, which I felt I will not write it here. According to me, these were the three statements that were primarily provided, and fourth statement was something else and not related to culturing of the CSF. I feel then the best answer should be blood culture and the CSF from the shunt tap. this possibly is the best way to identify a shunt infection. See, there have been many people who have said that because these infections or bacteria primarily are attached to the shunt device, they are not present in the CSF, flowing CSF. So possibly a even better way of identifying shunt infection is to take out the shunt and to culture that shunt device. But more acceptable way is to obtain the CSF from the shunt reservoir, see the growth. In case the confirmation is there that this is a case of shunt infection, then you obviously have to take out the shunt. And after taking out the shunt, then you have to treat the child by giving intravenous antibiotics. And then you have to obviously do repeat CSF cultures till the CSF cultures are sterile. After the CSF cultures are sterile, then obviously replacement shunts have to be put. So if a child is suspected of having a shunt infection after a shunt has been placed, and here I think shunt infection should be suspected more, not shunt occlusion, because of the fact that the child is having fever. So in case shunt infection is suspected, in those cases, obtaining the CSF for culture is of primary importance. And there is a lot of debate, as I'm again and again saying, whether CSF by direct lumbar puncture, it's a much more acceptable technique to all because it's very easy to do. Obtaining CSF from the shunt reservoirs is a much more complicated process according to me. I'm not a neurosurgeon, but according to me, it's a much more complicated process. A shunt tap and obtaining a CSF from the shunt reservoir in comparison to a lumbar puncture, which is done by the residents also. So if you see the convenience, and in case, and this is what some people believe, that in case the results in both cases, how much growth can be expected, in both cases is almost identical, why not do a lumbar puncture rather than going in for a shunt reservoir and then obtaining the CF, because that is obviously associated with high morbidities and mortalities. So again, what is choice D? If choice D was something else related to again CSF culture, then that could have been the possible answer. But if that was not related to CSF culture, the fourth choice, then according to me, the best answer should be CSF for shunt tap, from the shunt tap should be obtained, and blood cultures obviously should initially be obtained to decide the IV antibiotics that we need to give in this case. So this appears to be a case of a shunt infection. Another question was question number 11, which is a question on a 12-year-old boy or a 12-year-old child who is suffering from myoclonic jerks throughout the day since 1 month. Teachers report irritability, loss of concentration, EEG shows burst suppressions. Parents give no significant history other than fever with rash that the child had 1 year old. I think this again is a pretty simple, doable question. This is most likely a case of a subacute sclerosing panencephalitis. SSP normally follows 7 to 13 years after a primary measles infection. It can be either because of an altered measles virus or the altered immune system of the child. It's one of the rarest complications that is seen in these children, but when this complication occurs, it can be life-threatening. The early symptoms of SSP initially may often be missed because these symptoms in stage 1 is usually very, very non-specific symptoms. So most of these children, initial symptoms may be just behavioral changes or school performance of the child getting affected, which is something which can often be missed by the parents. The classical feature of SSP is when stage 2 appears, because when stage 2 appears, that is the time when the child starts presenting with the classical myoclonic jerks, which is present in our question also. So in our question also, myoclonic jerks were present in the child. And abnormal movements. The myoclonic jerks and abnormal movements are often features of the second stage when SSP sets in, and this myoclonic jerks often are treatable with carbamazepine. So carbamazepine has been considered to be one of the drugs of choice for the treatment of myoclonic jerks in children who have SSP. When stage 3 sets in, at that time these abnormal movements, they gradually disappear and are replaced by the chorioethetoid movements along with dystonia. And finally, when the child enters into the last stage, that is the time when the blood pressure centers, the respiratory centers, all these centers in the brain start getting affected. So that's obviously is the penultimate stage to death which occurs in these cases. This is a condition which often is a life-threatening condition, very rare, but often is a life-threatening condition. And in my eGurukul videos, I mentioned this also. You can see I mentioned that SSP is very rare, but yet is a known complication of measles. Occurs 7 to 13 years, much later period of time. And here also the mother is recollecting that there was an episode of fever and rash in the child, which possibly was measles only. That is why this is SSP. Another clue to SSP here is the presence of this typical EG, which is not pathognomonic, but often is seen in these cases. Suppression burst activities. So suppression burst activities are seen in the EG, which classically is seen in stage 2 when they are myoclonic jerks. So if you have a child presenting with these type of findings, identifying the measles antibody in the CSF may be one of the best ways to identify this disorder. So looking for the measles antibody in the CSF, and this was one of the choices, which was the correct answer. Treatment of SSP is often been challenging. So normally symptomatic management is usually done, but there have been some reports that certain antiviral drugs have been used with or without interferons. Isoprenosine is one of those drugs which have been used, which with or without interferons has been shown to at least improve prognosis in a set of children, a subset of children who have SSP. Otherwise, in most cases, management is primarily symptomatic. And as I told you, carbamazepine is one of the drugs of choice for controlling the myoclonic jerks that are seen in SSP. So there is no confusion about this statement, this question. Answer is SSP. So anti-measles antibodies in the CSF should be looked for. Coming to question number 12, again students are telling me that there was a question on a typical presentation of a child who has congenital hypertrophic pyloric stenosis. And the metabolic abnormality that was asked, answer was hypochlorimic hypokalemic alkalosis, which again I have in my classes discussed. The congenital hypertrophic pyloric stenosis typically presents with the classical 3 Ps, which are a pyloric mass, peristaltic waves passing from left to right, and projectile vomitings, which typically start from about 3 to 4 weeks after birth. Normally these projectile vomitings are not present from birth. The typical metabolic abnormality that is seen in these cases is hypochlorimic hypokalemic alkalosis, metabolic alkalosis, which was the correct answer here. Now, just before I was making this video, I was in contact with some students also. That a question that one of the students has said was possibly a student has told about a question which was on Turner syndrome also, which was question number 13. So again, I am not knowing the exact question, but the students say that the question was something like this: a mother has got a child who has a short stature, then low posterior hairline, then presence of cubitus valgus, all of which are findings that can be seen in children or girls who have Turner syndrome. So the question that they had asked was on ultrasound, what findings can be seen? So in ultrasound, the choices that the student was telling me, one of the choices was streak ovaries. So streak ovaries can be seen in these cases. Something like streak ovaries can be the correct answer. Again, I really do not know what exactly the choices were, but the student told me that streak ovaries was one of the choices that was given. So answer here is, so if you actually see all the questions that have been asked in the pediatric exam, except for around 2 or 3 questions, which were more of conceptual questions, most of the questions were easily doable in the exams. And that is how pretty much how you should expect the paper to come in the exams. Very, very rare circumstances when you get papers which usually are very, very tough papers, which everyone finds very difficult to answer. Very, very rare. Most of the questions that are asked in the exams are doable questions if you have studied properly. If you have attended your lectures properly, if you have made your notes properly, if you have studied those notes, and if you have done a revision of those notes, they're all doable questions. If not all, 90% are doable questions, which will decide your rank. Remaining 10% questions are to come to the topmost part. And even those, I think, remaining those 10% which are difficult questions are the questions where if you apply the concepts, you are easily able to answer at least another 7 to 8% out of those 10% questions. So again, I'm telling you, this is what I have gained from the students, the questions, and our students have been very kind enough and helpful enough to provide those questions. I can understand if someone will ask me that when I'm giving my exams, please remember the questions and recall later on. It will be very, very difficult for any of us. But the students have been very helpful. I thank all the students who have been able to contribute to these questions. Thank you very much. And I wish you all the best. These questions, I've framed these questions, and based upon whatever information I could get from those questions and from the limited choices that were available, I've been able to give the answers. Again, I'm telling, because these questions are not completely framed questions, it's only the second day. Yesterday was NEET. So because these questions are not properly framed, any statement which was missed in this question can change the answer of the question also. So whatever I'm providing, the answers are strictly answers based upon the information that is present right now in the question and the choices that are right now known to me. If the choices again differ or new choices appear later on, probably the answer can change. But I'm sure at least now you will have a basic understanding that this is the answers to the questions that have been asked. There might be 1 or 2 more pediatric questions. If there are more pediatric questions which come at a later date and I get a full stem of the questions and all the choices, I probably will later on come up with a complete video of this recall session of NEET PG 2021 pediatric questions. So thank you very much. I wish you all the best for a lovely score in these exams. You have all done the hard work. I wish you all the best for your results. I'm sure you all will get the desired branch that you all want. You have done all the hard work. I've seen our students doing all the hard work. I'm sure you'll get the desired results of your choice. Thank you once again for contributing to these questions. All students, thank you once again to contributing to whatever you could provide. The questions, the choices, thank you, and best of luck for your results. So I'm Dr. Pankaj Tikku, Pediatric faculty, saying thank you very much. Goodbye.